Hello everyone, welcome to Challenging Concepts on the Articulations Chapter. So it's Chapter 8 of the Mariab textbook. So first of all, what are articulations or joints? Joints are where two or more bones meet, right? So let's talk about the two classifications of joints. They are either classified as functional classification or structural. Functional classifications based on how much movement that joint allows, okay, while structural will talk about what materials make up that joint, whether there's a joint cavity or not. So functional classification, there's three types of functional classification of the joints: synarthrosis, amphiarthrosis, and diarthrosis. So let's look at the two extremes. Synarthrosis, these are going to be immovable joints, so no movements. These joints do not allow any movements. Diarthrosis, which are considered to be freely movable, so a few degrees, 20, 30, 40, 50, even up to 180 degree movements, some even more actually. When we have hyperflexion, we'll look at that. They are freely movable joints. Amphi is somewhat in between, just a few degrees of movement. Okay, then structural is by the materials that make up those joints. We have fibrous, so it's going to be fibers that are making up this joint, the fibrous tissue joint. Cartilaginous, as the name suggests, it's going to be cartilage that forms. And then synovial, that's going to be the one with cavities. So let's look at fibrous joints. We have three types of fibrous joints. First one is suture. Suture we can see between cranial bones in our skull. Okay, so between the cranial bones we have sutures. Coronal suture we talked about, sagittal suture, squamosal, lambdoidal sutures. Those are all fibrous joints. Syndesmosis is the next one. I would suggest highlighting this one. Somehow most incorrect answers seem to come from a option of this in terms of joints. I feel that the reason is these are the only fibrous joints that allow some movement, and usually it has been confused with fibrocartilaginous joints, which we'll talk about in the next slide, which also allows some movement. So that's maybe where the confusion comes from. So syndesmosis allows some movements. Hopefully then you can recall that it's amphiarthrosis. Sutures and gomphosis are synarthrosis or synarthrotic joints. So two places you want to remember about syndesmosis we can find in the distal tibia and fibula joint. So right at our ankle we'll have some ligaments that join the bone to bone. That will allow us a little bit of movement, and it's made up of fibrous joints. So that's syndesmosis. Another one, a beautiful one, is between our diaphysis of radius and ulna. These fibers between the radius and ulna, those are actually called interosseous membrane. It looks like a nice membrane and is between two bones, so interosseous membrane. So these allow some movement and hence are classified as amphiarthrotic joints. Gomphosis, the easy way to remember is you think about gums. They're not really the gums, but they're within the teeth socket. Okay, so they're within the teeth socket, and these are periodontal ligaments. So you might have heard of periodontologist, right? So they deal with root canals, for example. So they are deep within the teeth socket, right? So these are keeping the teeth within teeth socket, and hopefully you also recognize that these will not move because we don't want our teeth to move. Then cartilaginous joints, there are two types. They are made up of two different cartilages and they allow different amounts of movement. So let's look at the first one, synchondrosis. Synchondrosis does not allow any movement and is made up of hyaline cartilage. Okay, the best one describing that is between the first rib and manubrium. Okay, so during breathing, every other rib kind of moves away during inspiration from our sternum, but the first rib does not. The whole rib cage will move with the first rib and the manubrium, the distance being the same. Then the next type is symphysis. So symphysis are fibrocartilaginous joints which allow some movement, so amphiarthrotic. The two places, hopefully you remember from tissues, is that we have fibrocartilage in three places. One is actually within a joint, it's not a joint. The other two are joints. So these are those two. So it's intervertebral discs as well as pubic symphysis. Those are both symphysis joints. They are made up of fibrocartilage and they allow some movement, amphiarthrotic. So we'll go into the next group, which is the synovial joints. They have a fluid-filled cavity. They are all diarthrotic. They allow a good amount of movement. Most of our limb joints are made up of synovial joints. So there are 6 distinguishing features of synovial joints. First is the articular cartilage. That's the cartilage that's facing the joint. It is made up of hyaline cartilage. The next is articular capsule. So if you imagine yourself within the synovial cavity, this will be the lateral walls of that space, right? So synovial articular capsule. It's made up of 2 layers, external fibrous layer and an internal synovial membrane. So the internal one, the synovial membrane, will be responsible for producing the synovial fluid, which we'll talk about in number 4. So synovial cavity or joint cavity is number 3. Synovial fluid, which is produced by synovial membrane. It's basically a filtrate of blood. It is a viscous slippery fluid that allows smooth movement of those bones involved in that joint. Then we have reinforcing ligaments. They can be intracapsular within the capsule or extracapsular. And then we also have nerves and blood vessels. Again, joint, if we hurt the joint, it can bleed. It'll also be painful. Okay. So in this picture, we have kind of 5 of those. You can see the nerves and blood vessels are not shown here. We see the articular cartilage in blue, the cavity with the fluid in this yellowy green, then the green membrane will be the synovial membrane, the purple is the fibrous layer, and then we can have intracapsular or extracapsular ligaments that are present. Then some synovial joints have additional features that make in within the joint. Fatty pads, as the name may suggest, they are collections of adipose connective tissue. They help cushion within that joint. They're found in the 4 major joints, our shoulders, a little bit in the elbow, in our knees and hips as well. The articular discs or menisci, meniscus singular, is found in our knees. Then there are 2 other features you want to remember about, which are found outside of the joint but help with the joint movement. Okay, so bursa, you may have heard of bursitis. A swelling of bursa is found outside of the joint. It's a fluid-filled cavity. It's a synovial fluid-filled space which takes up some of the stress, of the movement itself. Tendon sheets is like a little bursa, so fluid-filled sac, but it's wrapped around the tendons. So tendons connect muscle to bone. The next we're just going to talk about the stabilizing features that help joints, synovial joints. So there are 3 main features. One is the articular surface. So the way the surface, good example look at is the ball and socket. So one is round and one is cup shaped. So the ball fits into that cup. So that's the complementary nature of those surfaces, right? Then ligaments. So if we have multiple ligaments, ligaments connect bone to bone. The more we have and the way we connect them, they can also play a role. But the biggest one that plays the most role in stabilizing our joints is muscle tendons. Okay, so if we have a dislocation, they will give us, once of course it's healed, they will give us training or suggest training of muscles to build those muscles around that joint. Okay, so which builds the muscle tone and hence helps to stabilize it. So this plays the biggest role in stabilizing our synovial joints. So next we're going to talk about the types of synovial joints. There are six types of synovial joints: plane, hinge, pivot, condylar, saddle, and ball and socket. So planar joints are between flat bones, flat surface of bones, right? So between our carpal bones, between our tarsal bones, in our shoulder, between the clavicle and the scapula. So the acromial end of the clavicle and the acromial process also makes up planar joint. Then a hinge joint, you can think of it like a door, right, which kind of it's hinged onto the door post or frame. There's movement across. It's a nice, beautiful. So there's a trough, a little trough, and then a cylinder that fits into it, and the bones move about the trough. Okay, a good one is our humerus, the trochlea of our humerus, and then the ulna, the trochlear notch, kind of forms a trough. Another place, so that's in our elbow. Another place, our knee joints are also hinge joints. Even our between the phalanges in our fingers, in our toes, those are also hinge joints. Next, we're going to talk about pivot. So pivot joints, we have a rounded head and then a circle surrounding it. The circle does not need to be made completely by bone. The circle can be completed by ligaments. So in the elbow, we have a pivot joint that's between the ulna and the head of the radius. We also have a pivot joint at the atlantoaxial joint. So that's between the atlas C1 and axis C2. So the C2's dense process behaves as the rounded head, okay, around which the atlas will turn. So when we say no, when we turn our head from side to side, we are using the pivot joint between those two bones. Next is the condylar joint. So condylar joint, you can even think of it as a miniature version of a ball and socket. So we have an oval shaped end of the joint and a rounded head. The other side, they kind of fit in. The best ones to think about are between in our knuckles of our hands, so between the metacarpals and carpals. So we are able to do a circular motion of the finger, say example the index finger, because of the condylar joint. We also have condylar joint between the radius and ulna and the carpals and our wrist. So that's why we're also able to do make a circular motion of our wrist as well. Next is saddle. The only place we actually find this is just below or proximal in our thumb. So between the metacarpal that supplies the thumb side, so number 1, and the carpal, which is trapezium, that is a saddle joint. So you can think of as horse's saddle. So there's a concave and convex surface, but when you try to do a circular motion of the thumb at that joint, you're going to see it's not a nice smooth circle. It feels like something's jumping out. Okay, that's because of that saddle joint. Then ball and socket. So a nice spherical head with a cup-shaped socket, right? So our shoulder joint between the glenoid fossa of the scapula and the head of the humerus, between the head of the femur and then the acetabulum of the os coxae of the pelvic bone are good examples of ball and socket joints. Next, we're going to talk about movements. Whenever we talk about joints, we also have to consider movements. The names are easier rather than the axis. Axis, if you can get to it afterwards, that's great. But I suggest first try and figure out the movement in terms of the name nomenclature. Gliding movement, if you wave, you're just at the wrist, you're just moving the hand side to side slightly, right? That is gliding movement. We can also do that of our shoulders. It's between plane, it's within plane joints, right? So between flat bones. The next is angular movements. Flexion, we are reducing the angle, so natural position of our head. If we bend our head forward so our chin comes close to our chest, that's going to be flexion. So the angle between those bones are decreasing. Okay. Same thing with our back too. If we lean forward, that's going to be flexion as well. That's a good example of that. Same thing with our wrist, our elbows. Right. We can flex our shoulders. We can flex at our hip. Please note, the knee flexion actually goes backwards because the angle is at the back that they're referring to. Then extension will be the opposite of flexion. Now you're coming back, the angle is coming back from that bent position towards the center, the natural anatomical position. Okay, while some joints we can go further back, right? So those are going to be called hyperextension. So you're going further back. So your neck we can hyperextend, our back we can hyperextend, our wrist we can hyperextend. We shouldn't be able to hyperextend our knuckles, for example. We shouldn't be able to extend elbows, but some people can, right? But these are going beyond that 180 degrees of that natural position. Okay. Next is adduction and abduction. Adduction, you can think of it as adding, so you're adding your arms, your legs towards the body. So it's a movement towards the midline. So in this picture, if you look at this arm, this hand position coming towards this side, so you're adding towards the body. Okay, we can also adduct our fingers when you bring our fingers close to each other, or the opposite, when you take it away, it's going to be abduction, abduction. Okay, abduction is away from the midline. We can do that for our legs too. If we were to stretch out our legs towards the side so the foot goes that direction, would be abduction. Adduction, you're bringing it back. Okay, there's the picture for the leg as well. Circumduction actually goes along in that same axis when we do with our peripheral or periphery of our limbs, whether it's our hands or legs, we do a circle around. Okay. Next is rotation. Here we are rotating on the longitudinal axis. So it's medial rotation and a lateral rotation. So if you're standing straight, you turn your head towards the left side, that's lateral rotation. You bring it from that left hand turned side towards the middle back again, that's going to be medial rotation. Then you go back to the right side, or go to the right side, it's again lateral rotation. Okay, we can do that with our legs too. We can do that with our hand, the arm as well, right? So you laterally rotate, you're kind of bending your elbow and then your palms are facing outwards, and then you medially rotate, you're bending at the elbow and moving with the hand facing towards your abdomen. Okay. Next ones are some special movements. Elevation and depression. A good example is of our mandible. We lower the mandible. Depression of mandible, we bring it back up. Elevation, we can do that with our shoulders too, for example, right? Next one is protraction and retraction. Protracting is pushing outwards. Retracting, so if you're pulling in, right, you pull. This is a good picture as well of the mandible being protracted, pushed out, and then retracted, pushed back in. Then inversion and eversion are only to do with the feet. So you got to pay attention which foot this is. So pay attention to the great toe, right? Because if you're looking at the other foot, the opposite will be the direction for the movement. So inversion, you're bending the foot medially, and eversion, you're turning the foot laterally, right? Whereas if it was the next foot, so this one would be the left foot of this person. If it was a right foot, inversion will go in this direction, and then eversion the other direction. So you just have to be mindful of that. So rotating the foot internally, inversion; rotating it externally, eversion. We also have another special movement in relation to the foot. We consider in the foot, the angle can be considered depending on how you look at it. So both are flexion when you move the foot up or down. So toes up, think of the dorsal fin of our shark, for example. It's on the back, so you have to think of it analogous to our hand, right? So when we are anatomical position, when we are standing, the arms by our sides, the palms are facing forward. So the palms will be anterior, while the other side is posterior, which is called dorsal. So similarly, the foot is going to be the palm equivalent, called plantar region, and then the top will be the dorsal region. So dorsiflexion is bending the toes up, while plantar flexion is bending the toes downwards. And we want to use these directional terms rather than saying bending toes up, toes down. Okay, you want to describe it in dorsiflexion or plantar flexion, and we'll talk about this again when we learn in terms of muscles, what the function is or their action. We are going to talk in these kinds of words. Okay, the next one is in reference with the hand: supination and pronation. Supine position and pronated. So pronated, you're on the belly; supine, you're on the back, right? Another way I give this example of Oliver Twist: when he goes with the bowl, he asks for more soup, please, right? So he's holding this bowl, more please. So you think of soup, you're going to hold the bowl upwards, so supine palms are going to face upwards. When we flip them down, that's going to be pronation. Okay. The next one is also to do with the fingers. When we bring the thumb of the same hand, the thumb towards the fingers of the same hand, so we are considered to have opposable thumbs, right? So we are able to do that. That's opposition. Since we can do that, we can actually use tools with our hands to move, right? The next slide is about the knee joint. We'll talk a little bit more about the knee joint. Dislocations are very common, but there's also extra features that are useful for the knee joint. So we have collateral ligament, cruciate ligaments, and menisci. So we have two collateral. So lateral means on the sides, so they're going to be on either side of the knee. So we have a medial collateral ligament and a lateral collateral ligament. Another name for that is tibial or fibular collateral ligament. So hopefully you recall that the tibia is on the medial side of our shin, while the fibula is on the lateral side. So the fibular collateral ligament is the lateral collateral ligament, while the tibial collateral ligament is the medial one. The cruciate ligaments is actually at the posterior of the knee. They form an X. Okay, so you may have heard of ACL, PCL. They're referring to these. Okay, similar to MCL would have been medial collateral ligament. Okay, anterior cruciate ligament, and then posterior is behind it. Okay. Then we also have two menisci in our knees. They're called lateral meniscus and medial meniscus. The medial one is basically sitting on the medial side, the lateral one on the lateral side. Okay, so some extra features of the knee joint. One last thing I want to talk about is some common, two of the commonest disease of the joint, which is osteoarthritis. Normally they just call it arthritis sometimes, and then rheumatoid arthritis, the next common. So osteoarthritis is considered the wear and tear arthritis. Here, whatever joint that person uses a lot of can develop osteoarthritis, right? Usually the cartilage gets destroyed. We have bony pieces coming, bone that gets grown in, and then bone also is getting crushed because there's no cartilage to protect them, right? Rheumatoid arthritis is an autoimmune disease, so it is a disease that our own body produces immune antibodies against our own cells, right? So it destroys the joint. I hope you found this video useful. I will catch you in another video. Have a great day.